Hello everyone, welcome again to Easy Medicine. So this is a continuation of section 1 of coronary artery disease. Today we are going to discuss about the management of coronary artery disease, starting with the management of stable angina. So let's start with the evaluation. So when the patient comes to you with angina, the first step would be to assess the pre-test probability. Pre-test probability means you are assessing whether the patient is likely having an anginal chest pain or some other kind of chest pain. So the pre-test probability requires age, sex, chest pain, whether it is typical or atypical, history of smoking, diabetes, hypertension, and dyslipidemia. Based on these risk factors, the pretest probability is assessed. And if the pretest probability is low, then there is no further evaluation required. You can rule out as some kind of non-cardiac chest pain. If the pretest probability is so high, you can directly go towards the coronary angiography. The question arises when the pretest probability is intermediate. Now, when you look at a resting ECG, see whether the patient is having any ST segment depression or elevation. If there is an ST segment elevation, it is obvious that the patient is having STEMI, and if there is any ST depression or T wave inversion, then it could be NSTEMI. So we'll go to the management of STEMI or NSTEMI. But if the resting ECG is showing any left bundle branch block or any other arrhythmias, then the assessment for infarction is not possible. So then you have to do stress testing. If the resting ECG is normal, then again for further evaluation, you need a stress testing. What stress testing you need to do? Let's look at that now. The first test among the stress tests are the first test among the stress testing is exercise ECG. If the exercise ECG shows ST segment depression by more than 1 millimeter, then it is indicative of ischemia. Then the next step would be to do coronary angiography to identify which vessel is involved. The second investigation is a stress echocardiography, where you are going to stress the heart and you are trying to identify the wall motion abnormality or any reduction in the ejection fraction by doing an echo simultaneously. Next is cardiac MRI. In the cardiac MRI as well, this is also kind of stress test where you will subject the patient to undergo exercise or vasodilators. We will discuss them consequently, where you will be able to identify any perfusion defect, abnormality of the wall motion, or any reduction in the ejection fraction. And MRI is very sensitive in identifying the myocardial scar. And lastly, we have some investigations which are related to the nuclear medicine, which are PET scan and SPECT scan. They will also identify the perfusion defects and wall motion abnormalities. If any of the abnormality is found in any of these stress tests, the next investigation is coronary angiography to identify any coronary artery occlusion. Now let's look at the evaluation deeply. The first investigation is to do a resting ECG. Resting ECG is usually normal only when the patient comes to you to the casualty or the OPD while the patient is having pain. Only then you may appreciate the STT wave changes. Otherwise, the ECG is normal. Anyway, you will do the cardiac stress testing. So the patient may be subjected to some amount of exercise or certain drugs. That is what is the pharmacological stress. The pharmacological stress can be given to the patient by giving vasodilators like adenosine or dipyridamole. What will these do? They are going to vasodilate, and both the occluded vessel and a normal vessel will get vasodilated. But the problem is that when there are communications between the abnormal and normal vessel, the normal vessel which is vasodilated is going to steal the blood flow from the abnormal vessel. That is why the deprived tissue will be depriving of oxygen more and more, and further the patient will have ischemia and the patient will have an aggravated chest pain. So that is what is called as coronary steal. And you can also use cardiac stimulants like dobutamine. Dobutamine increases the cardiac contractility. Increased cardiac contractility means increased oxygen demand by the heart, and further the ischemia increases. So first investigation among the stress testing is exercise ECG testing. This is the initial procedure among all the stress tests. What will you appreciate? You will appreciate a flat or downsloping ST segment which is at least more than 1 millimeter below the baseline. And other T wave abnormalities or arrhythmias are not indicative of ischemia. They are not diagnostic of ischemia. Only ST segment depression, either flat or downsloping at least 1 millimeter, should be considered. Now then we have the stress myocardial radionuclide perfusion imaging, that is usage of SPECT and PET scans. Now let's just compare them briefly. The SPECT scan is cheaper and the resolution is also low. The gamma rays are emitted with the decay and radiation dose is high. The tracers that are commonly used here are technetium 99, tetraphosphine, or system-AB. You can also use thallium 201, which has the high radiation. And on the other hand, we have a PET scan where the cost is high, but the resolution is also high. And emission is positrons. Radiation dose is low, and the tracers that are commonly used are N13 ammonia, rubidium 82, and fluorodeoxyglucose can be used for assessing the viability of the myocardium. What are the contraindications for stress testing? See, the absolute contraindications are when the patient is already having angina in the last 48 hours. So, the rest angina within the last 48 hours is an absolute contraindication. When the patient is having unstable rhythm and when the patient is having a decompensated heart failure. And myocarditis is also a cause of heart failure when the patient is having myocarditis or severe aortic stenosis or severe pulmonary hypertension and active infective endocarditis. These are all the absolute contraindications for stress testing. There are some relative contraindications as well. When the patient is having anemia and hyperthyroidism, the heart is already under a lot of stress. And recent stroke or transient ischemic attack, when the blood pressure is more than 200 by 110 millimeters of mercury, advanced heart block, severe HOCM, and recent myocardial infarction and heart failure. So, all these are the relative contraindications for stress testing. Now, let's see how the pharmacological stress or exercise related stress is going to change the coronary circulation. Now, look at this in the first image. Here is a normal artery, and here is an artery which is occluded, and there is development of collaterals in between. See, when the patient is gradually developing these ischemic changes or the occlusive changes in the arteries, coronary vasculature also adapts with the development of coronaries in order to perfuse the myocardium, which is deprived of blood flow. So, here is an occluded vessel, and here is a normal vessel, and here is the collateral. So at rest, this is the collateral flow, and when you look at a PET scan, this is how it is. The orange color indicates the perfusion. On the other hand, when you look at an exercise based or a pharmacological based stress testing, you can see both the normal vessel as well as the occluded vessel are dilated. And because of this vasodilation, what will happen? The blood flow from the abnormal side is pulled towards the normal side, and the abnormal vessel is further deprived of blood flow, and the myocardium becomes ischemic. That is how it will appear on a PET scan or a perfusion scan. Hope you understood this. Now, when you talk about the cardiac MRI, we have already discussed it is going to assess the cardiac perfusion abnormalities, wall motion abnormalities, and it is very sensitive in identifying the myocardial fibrosis or viability. If you are not able to do any of these investigations, you can also do cardiac CT. You can do cardiac CT angiography. CT angiography will help in the assessment of a fractional flow reserve. This component will assess the coronary vessel stenosis and how is the flow across the stenosis, that is being assessed with the fractional flow reserve, and this can help us in guiding the PCI, that is percutaneous coronary intervention, or the placement of stent angioplasty and stenting. This can be used instead of the stress radionuclide testing. If the stress testing is contraindicated, then you can also do this CT angiography in the patient. The other modality is electron beam CT. This electron beam CT helps us in identifying the calcium deposition in the coronary vessels. This can be calculated by using the Agard-Stern score. Okay, Agard-Stern score. This gives the atherosclerosis burden in the patient in the coronary vessels. Now let's look at the management. The management of angina requires the vasodilators. The most important ones are the nitrates. The nitrates are combined veno and arterial dilators. They'll result in venodilation. So the venodilation will reduce the preload to the heart, and they will also carry out the coronary vasodilatation. Right? So reducing the preload on the heart will reduce the demand on the. So when the preload is reduced, the cardiac work will also be reduced. So the need for the heart to pump more will also reduce. So the cardiac workload is reduced. Now let's look at the management. The management of angina primarily requires vasodilators. The most important ones are the nitrates. Nitrates are combined arterial and venodilators. By doing systemic venodilation, they will reduce the preload to the heart. When the preload is reduced, the cardiac workload is also reduced. On the other hand, they will also do coronary arterial vasodilatation, so thereby increasing the blood flow to the myocardium. So it is reducing the demand and also increasing the supply to the heart. This is the best. If you want immediate relief in a patient, then you can use short acting drug, which is a sublingual or nasal spray of nitroglycerin. Then we have some other drugs like isosorbate dinitrate, isosorbate mononitrate, which are little longer acting. And try to maintain a nitrate free period of 8 hours to prevent nitrate tolerance. So when you keep on using nitrates for long, the patient will develop nitrate tolerance and the nitrates will not be able to vasodilate the vessels efficiently. So you need at least 8 hours of nitrate free period in every day. Next comes the beta blockers. The beta blockers, they will reduce the myocardial oxygen demand, they'll reduce the heart rate and reduce the blood pressure. And they will also be reducing the mortality. These are one of the important drugs which have shown to be having mortality benefit. And then we have calcium channel blockers. Not every calcium channel blocker can be used. The common drugs that can be used here are diltiazem, amlodipine, and verapamil. They will also carry out coronary vasodilatation, so thereby increasing the coronary blood flow to the heart. And they are usually indicated when the beta blockers are contraindicated or beta blockers are poorly tolerated. And the calcium channel blockers can be used in combination with beta blockers as well, except verapamil, because when you use beta blockers along with verapamil, it can precipitate bradycardia or heart blocks. Now we have ranolazine. Ranolazine is a drug which inhibits the late inward sodium current and that will also relieve angina. This is contraindicated in QT prolongation. Then you have a funny current sodium channel inhibitor, which is ivabradine. Funny current sodium channel inhibitor lowers the heart rate. This is primarily responsible for reducing the pacemaker activity and improves the myocardial oxygen balance by prolonging the diastole. And the ivabradine is usually indicated when the heart rate is more than 70, despite using maximal tolerable dose of beta blocker and if the patient is already having LV dysfunction. The other drug is nicorandil, which is an ATP sensitive potassium channel opener, and this can also be used to prevent angina. Now let's look at the secondary prevention. Now let's look at the secondary prevention. For secondary prevention, you can use antiplatelet drugs as well as statins. The antiplatelet drugs that we commonly use are the aspirin plus clopidogrel or ticagrelor. Prasugrel is not used commonly here. Prasugrel is used only when the patient is undergoing PCI. And statins, particularly high intensity statins, that is atorvastatin or rosuvastatin, can be used. Now, we have already spoken about the anti-anginal medication. When is revascularization required? Revascularization is nothing but doing angioplasty and placing the stent in the coronary vessels or doing a coronary artery bypass graft. When is this required in a case of stable angina? When the patient is having unacceptable symptoms despite medical therapy. When the stress testing is showing ischemia despite giving medical therapy. And if there is a left main coronary artery occlusion with more than 50% of its lumen with or without symptoms, or if the patient is having triple vessel disease with ejection fraction is less than 50% on a 2D echo, or if the patient is having a transmural infarct, post myocardial infarction with continuing angina. So all these are the conditions where you may have to do revascularization when the patient is having angina. Lastly, we are going to discuss a small topic called as Prince metal angina or variant angina. We have not discussed this in the first section, that's why I put it here. The Prince metal angina or variant angina can be seen in a patient with no background atherosclerosis. The spasm of the large coronary arteries with or without presence of atherosclerosis is responsible for angina here. And the triggers usually are the cold exposure, emotional stress, usage of drugs like cocaine, and a vasoconstrictor medications like ergot alkaloids. And the clinical features will be chest pain without any exertion, similar to that of unstable angina. And this is usually seen early in the morning, and with pain, the patient may wake up from the bed. The treatment is vasodilators that are nothing but nitrates and calcium channel blockers. This is all about the management of angina.